Assalamu alaikum. My name is Dr. Vikram and my moderator is Dr. Abbas Jafri. Today the topic of Journal Club is follow-up of patients with non-muscle invasive bladder carcinoma. The learning objectives of my topic is history and examination, urine cytology, check cystoscopy and imaging. So let's explain briefly regarding what is non-muscle invasive bladder carcinoma. It's a term commonly applied to the malignant urothelial tumors that have not invaded the retrusor muscles of the bladder. It comprises the relatively benign course of low-grade papillary tumors, the more aggressive clinical course of the high-grade tumor, including carcinoma in situ, TA, and T1 tumors. Now, what is CISTA and T1 tumors? Carcinoma in situ is a high-grade but flat malignancy confined to the urothelium. Papillary tumors confined to the urothelium are TA, whereas papillary tumors invading lamina propria are T1. These three are the non-muscle invasive bladder carcinomas. So in follow-up, what we must know in the history and examination of the patient, to ask regarding the hematuria, whether it is painless or not, whether it is invisible or visible hematuria, or the patient may have irritative lutes in the absence of infection, which is more commonly in carcinoma in situ, whether the patient has flank pain, unilateral or bilateral, which could be secondary to the involvement of the ureteric orifices. Patient may present with the acute clot retention, or he has or she may have systematic symptoms like fever, nausea, vomiting, general malaise, etc. And in physical examination, we must evaluate the mucosa of the patient. The patient may have excisional dyspnea, which could be due to anemia or have a significant weight loss. So now, let's talk about the risk group of the patient. This is important because according to the risk groups, patient may the follow-up mainly depend on these risk groups. According to the American Urological Association risk stratification, it is divided into three risk groups: low risk, intermediate, and high risk. In low risk, when the tumor is low grade, solitary, TA, and less than 3 cm, or papillary urothelial neoplasm of low malignant potential. In intermediate risk, recurrence is within 1 year, low grade TA, or solitary, low grade TA more than 3 cm, low grade TA, or multifocal. High grade TA less than 3 cm. Remember, this is the only high grade which came in the intermediate risk. High grade TA less than 3. All other high grades are in high risk group. So in high risk group, high grade T1, any recurrent high grade TA more than 3 cm or multifocal, any carcinoma in situ, any BCG failure in high grade patient, any variant histology, any lymphovascular invasion, or high grade prostatic urethral involvement. Now coming to the surveillance is mainly depends on cystoscopy and urine cytology. Although the accuracy of both tests relies on subjective and operative dependent, the traditional presumed status in the gold standard has been widely accepted. The timing and frequency of surveillance, cystoscopy, cytology, and upper tract imaging can be varied based on the risk of recurrence and progression. Now, let's know about the cytology. It involves the microscopic evaluation of stained cellular smears from the urine. It represents a pathologist interpretation of the morphologic features of shed urothelial neoplasm, of shed urothelial cells. Poor cellular cohesion in high-grade tumors, especially carcinoma in situ, enhances the yield. A positive urine cytology strongly predicts the malignancy regardless of cystoscopic or radiological findings in the vast majority of patients. It has high specificity but low sensitivity for high-grade and low-grade tumors, including carcinoma in situ. The EAU guidelines suggest in patients with TA grade 1 or 2 or low-grade bladder cancers, urine cytology should be considered in those not willing or not fit for cystoscopy. Patient with high-grade with high-risk tumors, urine cytology at 3 months. If negative, then repeat at every 3 months for a period of 2 years, and every 6 months until 5 years, and then yearly. During follow-up in patient with positive cytology and no visible tumor in bladder, mapping biopsy or photodynamic diagnosis, guided biopsies, or in extravesical locations that a ureter or kidney is recommended. The AUA guidelines suggest urine cytology is recommended as per surveillance cystoscopy follow-up, which we will discuss in later slide. Now, surveillance cystoscopy, it is the office-based cystoscopy offered rapid, relatively painless access to urothelium. There is a high positive predictive value with cystoscopy. The endoscopic appearance cannot reliably predict tumor stage or grade. Fluorescence cystoscopy can improve the detection of carcinoma in situ and papillary tumors. Recommendations for follow-up are mainly based on retrospective data, and there is lack of randomized studies investigating the possibility of safely reducing the frequency of follow-up cystoscopy. The AUA guidelines suggest the first cystoscopy after TURBT at 3 months is an important prognostic indicator for recurrence and progression. The first cystoscopy should always be performed at 3 months after TURBT in all patients with PTA, T1 and carcinoma in situ tumors. In low-risk tumor, the risk of recurrence after 5 years is low. Therefore, in low-risk tumors, after 5-year follow-up, discontinuation of cystoscopy or replacement with a less invasive method is considered. In high-risk tumors, patients should have cystoscopy at 3 months. If no recurrence, and cystoscopy should be repeated at every 3 months for a period of 2 years and every 6 months until 5 years and then yearly. No non-invasive method can replace endoscopy. American Urological Association guideline in low-risk disease, 3-month cystoscopy is recommended after initial resection and annually beginning 9 months after initial surveillance if no recurrence found. No surveillance cystoscopy is recommended after 5 years in low-risk diseases. In intermediate risk, every 3 to 6 months for subsequent 1 to 2 years, every 6 to 12 months for subsequent 2 years, annual cystoscopy lifelong. Restart clock with each recurrence. In high-risk disease, every 3 to 4 months for 2 years, 6 monthly for 2 years, and annually for lifetime. Restart clock with each recurrence. Now coming to the imaging, when it is indicated or not, the incidence of upper tract urothelial carcinoma after treatment of non-muscle invasive bladder cancer has been reported from 0.002% to 2.4% over interval of 5 to 13 years. The surveillance, epidemiologic and end result database showed that 0.8% of bladder cancer patients develop upper tract tumors. So surveillance is of little value until the patient has hematuria or high-grade tumor, especially if it is near the ureteric orifices. The appearance of upper tract disease is associated with mortality rate of 40 to 70%. The follow-up strategy must reflect the risk of extravesical recurrence, that is prostatic urethra in male and upper urinary tract in both genders. The risk of upper urinary tract recurrence increases in patients with multiple and high-risk tumors. The EU guidelines suggest regular upper tract imaging is recommended for high-risk tumors. For a positive cytology and no visible tumor, upper tract is recommended besides bladder biopsies. In AUA guidelines, no routine surveillance upper tract imaging is recommended in asymptomatic patients with a history of low-grade non-muscle invasive bladder carcinoma. In the setting of intermediate and high risk, patient consideration of surveillance of upper tract imaging at 1 to 2 years interval is recommended, especially for recurrence or hematuria. And annual imaging for 2 years is recommended in high risk group, and then lengthening interval is considered if no recurrence or hematuria is found. Surveillance strategies should be individualized on the basis of risk of recurrence in the bladder and extravesical sites. Besides CT urogram, MRI retrograde, uretropilography, ultrasound with full bladder is recommended in selective patients when, for example, if the patient has come with renal failure or having allergy to contrast. Now I have some simple questions for you guys. This is a scenario of 40 years old female came in OPD with a history of painless hematuria for 1 month. Ultrasound full bladder showed 3 to 2 centimeter hypoechoic lesion at the left lateral wall of urinary bladder. TURBT was done and biopsy came out to be transitional cell carcinoma grade 3 TA. Detrusor muscle included but not involved. Can anyone tell me in which risk group patient falls? Yes, intermediate risk group. And another scenario of 60 years old male came in ER with mild hematuria. Ultrasound full bladder showed 2 into 5 centimeter mass in left lateral wall. Cystoscopy and TURBT done. There was about 3 centimeter lesion at right lateral wall. Biopsy came out to be transitional cell carcinoma with ischemous differentiation grade 1 TA. Detrusor muscle included but not involved. Yes, this is a high grade tumor. High risk tumor, high risk group. Now this is the this is the graphical representation. Sorry, algorithm. This is the flow chart. How to follow patients with the non-muscle invasive bladder cancer. Now, again, this is as I explained earlier. This is in 3 risk group. In low risk group, cystoscopy at 3 months. Now, this is cystoscopy at 3 months, regardless of any risk group. We must do cystoscopy at 3 months. If it is negative in low risk group, cystoscopy at 12 months, and then yearly for 5 years. And this is the weak recommendation. Positive or suspect cystoscopy during follow-up. Now again assess whether the tumor is papillary, tiny tumor or large tumor. If it is a tiny papillary recurrence, consider patient's age, comorbidities and preferences. Office fulguration or surveillance, and then follow-up cystoscopy scheduled individual. Now if in follow-up we found the larger or non-papillary recurrence, TURBT, biopsies from abnormal looking mucosa, bladder random biopsy if indicated, prosthetic ureteric biopsy if indicated. Then wait for the pathology to come and then treat accordingly, manage accordingly, whether it is invasive or non-invasive bladder carcinoma. Now, if the patient is in intermediate risk group, as I explained, in all cases cystoscopy at 3 months. If negative, cystoscopy at 3 to 6 month interval until 5 years, and then yearly. Now, positive or suspect cystoscopy during follow-up, then do TURBT, biopsies from abnormal looking mucosa, bladder random biopsy, and then consider pathology report and manage accordingly. Now, if the patient falls in high risk group, T1 or TIS or high grade or multiple and recurrent and more than 3 centimeter. Now, what is the highest risk tumors? When tumor is T1 high grade with carcinoma in situ and T1 high grade with carcinoma in situ in prosthetic urethra. Multiple T1 high grade and T1 high grade with more than 3 centimeter when it is have lymphovascular invasion or some variant of urethral carcinoma. If yes, then explain the risk and consider radical cystectomy. And the second option is intravesical BCG for 1 to 3 years. Cystoscopy at 3 months is a strong indicating. If negative, cystoscopy and cytology every 3 months for 2 years, every 6 months thereafter until 5 years, and then yearly. Positive cytology with no visible tumor in the bladder during follow-up, recheck upper tract with a strong evidence. And random biopsies, prosthetic urethra biopsy in men, if available, use photodynamic diagnosis with a fluorescence guided. And if the patient not fall in the higher risk group, then again intravesical BCG for 1 to 2 years, cystoscopy at 3 months, and then if negative, cystoscopy and cytology for 3 months, and then for 2 years, and every 6 months for thereafter until 5 years, and yearly. Again, positive cytology with no visible tumor in bladder during follow-up, recheck upper tract by random biopsies in prosthetic urethra in men, and if available, use PDD. Thank you.
Yes, ma'am.
Dr. Vikram, when we divide these tumors into risk group like low risk, intermediate, or high risk, what do we mean by risk? Risk of what?
Risk of recurrence, sir.
Is it recurrence or progression? Or
Sir, both. If it is involving ureteric orifices, then yes.
Regarding the non-muscle invasive tumors, it's very important the second TURBT, because in non-muscle invasive tumors, there's a percentage of 13 to 24% in which your initial biopsy was non-muscle invasive, but after the second biopsy, in these particular cases, they are muscle invasive, T2 and above. So the role of second biopsy or second TURBT at 2 to 6 months, 6 weeks, it's very important and crucial. So, the management plan is totally changed from non-muscle invasive to muscle invasive tumors.